Thank you for that. How do you think PET PSMA imaging is going to impact therapeutics in terms of whether radiation to metastatic disease, oligometastatic disease, using SABR technology? Where do you see radiation oncology utilizing this technology as a means for therapeutic treatment of disease?
Yeah, so I think, again, same thing there. We're spotting things earlier. And so does that lead time give us actionability that improves the natural history or affects the natural history of disease? I think the jury is still out whether that's true, right? We have certainly a couple of different phase 2 randomized trials, the STOMP trial by Pete Oost and the Belgian group, as well as a Futran in the US, the Oriole trial, in which both randomized observation versus SBRT or SABR for oligometastases. And very interestingly, in Futran's trial, he looked at a subset of patients who had PET PSMA staging versus not, or at least the question being, well, if you got rid of all PSMA-avid disease as compared to conventionally defined disease, you get better outcomes. And yes, you did in terms of delaying hormone therapy initiation, which is, I think, a meaningful endpoint, but not the same as survival. So clearly, PSMA-PET is going to help better define oligometastatic patients for treatment. Whether it again affects long-term natural history is a whole nother question, but I don't think we can ignore the fact that it changes treatment history at this point, which is important, right? It has quality of life impacts. Secondly, I think in terms of the management of oligometastatic disease, I think the question also is the question of treating the primary. In Stampede, as we know, established level, at least level 2 data, it's post hoc pre-planned analysis based on stratification that primary site radiation improves survival in lower burden by conventionally defined imaging scans, patients. But a lot of people are saying, oh, this patient has a lot more PET PSMA defined disease than you saw on the conventional imaging. I think you got to be careful there. I would advocate saying that you don't know that those patients do not benefit to use double negative from primary site radiotherapy just because you found a lot more in PET PSMA. We know there's more, and we know that PET PSMA is insufficient. There's more disease out there than you can see. Okay, and segueing from that, so I would say your low burden metastatic patients cannot be defined by PET PSMA. It's low burden by conventional imaging for the selection of primary site radiotherapy. The last segue there is in the metastatic setting, of course, is the question of, well, what do you do with these relapses after local therapy? And I think there you're seeing, again, the value of a negative PET PSMA scan. So in a PET PSMA scan where you have these lymph nodes relapse, I think we've known a long time now from surgical series as well as SABR, that the single node you see is not all there is. There's going to be more disease there. And I think we have to be careful, again, not to overinterpret. I think you should treat these patients aggressively with regional salvage, but it has to be comprehensive in most healthy patients. I don't think it can be spot treatments. Spot treatments are more philosophy for like the Oriole trial and STOMP, I guess, at the beginning, for you're delaying hormone therapy purely for quality of life impact without really knowing if we're going to impact survival long term. And that's what's worthwhile. For radiopharmaceuticals, the last era on this continuum, certainly radiation, as we often say, is one of the best drugs we have for cancer in general. Now that's a systemic therapy, I think we're seeing the power of delivering a potent agent like radiation that's not just cytostatic, but actually cytotoxic to areas of disease based on a highly specific, small molecule, targeting of or antibody targeting of PSMA. And I think that's an area that's going to explode for sure. And we're just waiting to see what the big splashes will be in terms of CRPC and the CSPC setting. And as you know, they're moving into even the upfront localized setting. And so very exciting times for us. I think we had to pair all this with an assessment of side effects, cost, and toxicity from the patient perspective. I don't think we can get too excited too early. Got to test all these things. And certainly we in radiation oncology have been guilty in the past about liking our new technology and throwing them out there. I think we can very quickly miss our window to validate the benefit of PET PSMA in all of these contexts I just listed out if we don't rigorously test it prospectively. And I think people are doing a better job now than we did maybe 20 years ago.
When you're mentioning radiopharmaceuticals, you're mentioning things like Pylarify? Is that what you're alluding to?
Well, Pluvicto. So by radiopharmaceuticals or theranostic or therapeutic radiopharmaceuticals would be what I was referring to, like Pluvicto, which is the trade name for the lutetium 177 targeting PSMA product by Novartis.
Got it. Thank you. And I'd read the Oriole study as well. Very theoretically appealing, although I can appreciate the nuance that you're offering.
Yeah, and I think the PSMA targeting is going to make an impact there. I think certainly you're right. If we have a PSMA stage patient with oligometastases, I feel a whole lot better that we're going to drag out things.
For a few instances through our conversation, we've alluded to upfront treatment, focal therapy, lesional therapy. Do you envision or foresee a future where we'll be using PSMA technology, maybe in combination with MRI technology, to offer lesional treatment as precise as possible to kind of maintain the prostate gland without whole gland therapy?
I think it's already happening. And there's two parts of this. One is the higher risk patients where you're trying to figure out, is there a sub volume of the whole prostate you need to boost a higher dose? That way you can get the same benefits without the side effects of higher dose boosting the whole gland. Um, uh, and on the lower risk side, can you just do focal therapies, like you said, to have, which is very in vogue right now, to get better quality life outcomes without sacrificing outcome. So on the higher risk side, clearly MRI has already established the principle, because there's a phase 3 randomized trial called the FLAME trial that established a biochemical control benefit without increasing side effects by doing lesion-only dose painting. This has now been written into our ongoing NRG-GU10 phase 3 trial in the United States. We're allowing microboost, which is what it's called, where you're just boosting the dominant lesion, and you're planning the radiation as if you're not doing any boost at all. So all the normal organs at the same dose, basically as if you were not doing the boost. So you're taking what's free, as it were, with the modern technology. And I think that's very interesting. The addition of PSMA to this will be is very clear that if you look at the whole mount versus MRI or PSMA imaging correlate studies, the MRI dominated disease is not one-to-one in pixel to tissue. There's going to be more disease than you can see on the gland, even with high quality MRI programs. PSMA, when you add to MRI, clearly is more sensitive to picking up the microscopic extent of the disease, and better defining things for that lesion boost. There's an ongoing German phase 3 trial that's using PSMA for that lesion boost for that purpose now as well. I'm very interested to see how their outcome will be, whether they get even better outcomes long term. Lastly, in the converse side, like you said, for focal therapies like HIFU, tool system, we have a big program here at UT Southwestern, cryo, a lot of work being done in this area. Everyone's focused on MRI right now, but you're clearly under treating disease. And that's maybe okay in the lower risk patients because we don't really see a major benefit of treating them anyways, which is my big criticism of a lot of focal therapy approaches. But PSMA should technically help the marginal failure risk in those patients. And yes, I know it's more uptake in higher risk disease, but you see it in your Gleason 7s as well. So if you're stepping into the Gleason 7 world of focal therapy, which I think is highly controversial, I think PSMA has a role, making sure you're not missing the margin disease.
How was PSMA utilized in your trial design? You mentioned about the NRG-GU10 trial. In our discussions before we started this interview, you had mentioned that PSMA technology was utilized in the design of the trial. I'm curious how you used it.
Yeah, so it was part of discussion. So everything in our trial is based upon anything in the current phase 3 trials. Most trials going through NCI and CTEP are going to be for good reasons saying, well, wait a minute, you got to make sure you're picking endpoints that are validated surrogates for survival as much as possible. And that PSMA-PET detected metastasis is not necessarily the same thing as conventionally detected metastasis in terms of impact of survival. Like we just talked about, many trials before us, we would have picked up a lot of things on PSMA that you did not pick up now on conventional, or would not have picked up on conventional before. And so are those surrogates for survival in the same way conventionally defined metastasis? Clearly not. And so right now, at least in the NRG-GU10 trials, as well as the other radiation trials that I'm aware of, almost all of them require a conventionally imaging defined metastasis endpoint or metastasis-free survival endpoints as surrogates. PET PSMA, however, people acknowledge is going to impact everything. We knew it was coming out. Certainly other investigators knew it was coming out. And again, it's going to impact both the stage migration end. And so there we'll say, be careful, give people the benefit of the doubt. Don't stage migrate them out of curable therapy based upon an iffy finding in the retroperitoneum, which may not be real. So pretest probability is important. And secondly, on the back end, for detecting relapses, you're going to detect more of them earlier. So you can drop your metastasis rate by stage migrating people, but you might increase your metastasis rate by detecting earlier. And I think very smart people have modeled all this and come to the conclusion, we'll see. So I think the cleverest thing that we saw from very interesting advisors and on all these trials, and what I got to sit in as a junior investigator and listen to very smart people design this, is they basically make these as correlate endpoints, right? So they're not the primary endpoint, but they're very acknowledging this could be an experimental or sort of exploratory endpoint or secondary endpoint for that matter, where you're looking at PSMA defined endpoints, and we'll see how that all impacts everything in the future.
Sounds like there's a lot that we are going to find out very excitingly in the future. Hopefully, not too far along, not too far away. Excuse me. All right, well, Dr. Desai, I think that about wraps it up for us. I want to thank you for taking the time to speak with us and for educating all of our viewers and me in particular. I very much value your time. Thank you so much.
Thank you so much for your time and being patient with me, and you have a great day.
You too. All the best.